You're here, which we appreciate. My name is Claire Deerhoy Clark, and I am the current chair of the Women's Wellness Committee of the San Diego Psych Association. And I am pretty new to this role, starting this year. But when I started, I really wanted to do some kind of event for women and women's health. And of course, there are plenty of things to choose from right now in that regard. But fortunately, Tracey Chester, who is also a member of the committee, floated an idea of doing something on women's health and chronic pain, which is a passion for her. And she's done some presentations in the committee meetings around it. I think it's a pretty relevant topic for most, if not all of us. I'm sure if we're not personally dealing with chronic pain or chronic illness, we have a client or a patient or someone who is. So I think it's great that we have not just Tracey, but a couple different people from multiple different disciplines to talk to you about this in a really interesting way. Unfortunately, one of our presenters, Dr. Autumn Backhouse, was really excited to be here, and she had prepared quite a bit for this presentation, but due to a family emergency, she is no longer going to be able to present today, which I know was a really hard decision for her, but we wish her all of the best and good energy and everything. Yeah, that's a bummer. But these four who are still here have a lot of really beautiful things to say, and I think are going to try to touch on some of those topics too. Let's see, I think that's it. Other random things, we are probably going to be ending closer to 12:30 today. We do have a sponsor from Crown View who's going to come up at one point, and I do think she has a raffle if you're interested in that. And what was the last thing? Make sure you sign in at the front if you haven't already. If you're interested in joining the Women's Wellness Committee, we do meet on the second Tuesday of every month. If you're not already a member, it's a pretty cool group of mostly women who are there to talk about issues related to women's health and women's wellness. We do mostly on Zoom meetings, but once a quarter we have an in-person meeting, which is pretty fun. So if you want more information about that, please just follow up with me on the break, or again, just make sure your email is on that sign-in sheet out there, and I'll make sure to follow up with you. Okay, we're gonna get started. Wait, I'm not ready. I'm not done yet. Okay, I have to say, I want to make sure everyone knows that this event is happening mostly because of Tracey, because of her being able to connect everyone else who's here, and her vision and kind of driving this train. So thank you to Tracey for getting this going and bringing up this idea. Yeah, absolutely. I was planning to introduce everyone, but do you want to do that part?
No, you can do it.
Okay.
I don't want to say.
Okay. So I'll start with Tracey. Tracey Chester is a licensed marriage and family therapist. She is an author. She has a book, which is on your table, about gaslighting in the medical system, which, again, if you have a client working with chronic illness or chronic pain, I think you probably can glean a lot from that. She's also a chronic pain specialist, and she is she does surf therapy groups with people with chronic pain, which is really cool. I wish we could all do more stuff that's like more, not just sitting in a room talking, because I feel like it's very useful. So yeah, in the time that she's been a member of the committee, Tracey is very engaged. She always has stuff to share with people when they're doing meetings and presentations and questions, and has just been such a great part of our committee. So thank you so much. Thank you. Do you want me to do the rest of them? Thank you. Thank you. All right, Lisa. Lisa McJunkin is a licensed marriage and family therapist with a strong background in a lot of different areas, which I actually didn't know this, but she is worked with integrative trauma recovery, couples therapy, executive coaching, operator's syndrome, and psychedelic assisted therapy. She is a leader in holistic mental health care and conscious leadership development. She is the owner, or the COO, I should say, of Daydream MD. And she's going to be talking about healing the pain body, ketamine-assisted therapy, trauma, and the nervous system. Lisa was also the lead of the trauma program at Sharp Mesa Vista when I was an intern. So she knows a lot about trauma and all those different kinds of things she's going to be talking about. So very excited to hear from her. Then we have Dr. Jandra Mueller. Dr. Mueller is a pelvic floor physical therapist and educator at She Fits Physical Therapy. I think it's really cool we're going to have a pelvic floor specialist here because I personally have a lot of clients who work with pelvic floor specialists, and being able to hear from her around this issue I think is going to be really great. People that my clients have worked with on things like sexual trauma and medical issues and vaginismus and stuff have worked with pelvic floor therapists and found it to be really helpful in validating and normalizing. So very excited to have her here today and share her knowledge. She is also, it's okay. Dr. Mueller is also going to be talking about psychology meets pelvic health, collaborative care for women's sexual health. And she has served as the clinic director and director of education at the Pelvic Health and Rehabilitation Center. She is an international speaker, a published author, and a co-creator of Endometriosis 101, Moving Towards Better Care. So she knows her stuff. Very excited to also hear from Dr. Mueller. And then, last but not least, we have Dr. Michelle Sexton. Dr. Sexton is going to be talking about whole person care, the biopsychosocial model. She is a naturopathic doctor, a physician, scientist, author, speaker, and integrative medicine, sorry, I'm slurring my words in the morning, integrative medicine specialist across the lifespan. Dr. Sexton has been a champion of women's health since 1986. So is very involved in, it sounds like, advocating for women's health and very passionate about this topic, and we're very happy to have her knowledge and wisdom here. She's also the author of Eat, Sleep, Relax, Protect, Forget, an endocannabinoid guide to system wellness for women, which is the culmination of her lifelong love of women's health and the traditional ways that women have come together to support and heal one another. And I think that's her book right over there if you're interested. But yeah, let's just have a big round of applause just to start. This is going to be an amazing event with amazing women. And we can get going. Cool.
All right, I need the microphone.
Oh, you need the mic.
We're all fancy. So we're recording this. Oh, sorry, I got all your hair. We're recording this so you can watch it or other people can watch it. And if you're an LMFT or an LCSW or an LPCC, my clinic is CAMPed approved to give CEUs. So what I do is have you, I'll put the recording out there and have you listen, and by that point I'll have like a quiz and everything. I wanted to just start by showing you a little video about surf therapy, because it's going to come up over and over, and it's really hard to explain what it is. Usually when people hear surf therapy, they think, oh, I can't do that. I can't go out there and like surf those waves, but it's not that at all. It's very, we're in the white water, we're helping people. So it's just 5 minutes, and I made it. So it's very, let's see. So first of all, I just wanted to thank the Women's Committee for putting this together. I've been talking about chronic pain since about the age of 35. I'm now 56. I am a chronic pain patient. I have autoimmune disease. I had endometriosis. I had a severe neck injury that occurred when I was 27 and was not surgically fixed until I was 44. It was a pretty severe injury, so I spent many, many years really not functioning very well. And when you're not functioning very well and you're trying to start a new career, it's pretty hard and you feel pretty small and ashamed and like a burden. That's a very common feeling for patients with chronic pain. And then there's this feeling of, is this ever going to end? There was no, the surgery only occurred because one weekend I went paddleboarding and I went drumming. And those are two things one weekend with someone with a bad neck that you shouldn't do. But I had never slowed down because my coping mechanism with anxiety, depression, bipolar 2 was exercise. So I never really honored it, but I just kept pushing forward. And after that weekend, my disc herniated completely and my arm started to atrophy. And I went into a surgery 3 weeks later, and it fixed a lot. It fixed most of my pain. The next year I had to do one more, and after that I had no neck pain at all. And that sort of informed me in my practice as I work with people with spinal injuries. I'm not encouraging everyone to get surgery, but I see people on this conservative treatment merry-go-round, which used to consist of opioids, injections, spinal cord stimulators, you name it. And recently, I'm not going to really talk about this much today. It is in my book. There's 2 chapters about it, but essentially, opioids used to be the drug of choice for pain. And if you ask a pain doctor behind closed doors, they will tell you opioids are one of the most effective medicines. Now, they are not the perfect medicine, and they don't work for everybody. But I spent probably 8 years on opioid management for my neck. And without them, I wouldn't have been able to function. And right now, the CDC came up with a new guideline in 2016, which was after most of my pain, and pretty much just gave a recommendation that if you're in primary care and somebody keeps coming in, send them to pain management. But what happened is there was an overreaction by doctors, by pharmacies, by Medicare. They started to dictate how much opioid someone could take, and people started to get weaned off, and many involuntarily. And right now, and that was 2016, the CDC came back in 2019 and 2022 and said, wait a minute, you need to do a more personalized thing. You can't just say this limit is what you take and just wean people off. But right now, it never really got fixed. And most of my patients end up in the hospital and are not given any pain medicine. I did a kidney stone surgery in 2020, and they gave me Tylenol after. Yeah, so, and that's not uncommon. That's happening all over the place. I want to thank Michelle and Jandra and Lisa for coming and doing this with me. All of them have helped me professionally and personally. I met Michelle in 2018 or 2019 after I was done with my neck surgeries, but I was still having a lot of problems with my stomach, with intestinal things, bladder things, and I was saying to her, I'm not taking opioids anymore, but I'm still really suffering like widespread pain, and I don't know what's going on. And she is a cannabis expert, among other things, and I started to take a tincture, which was, she can talk more about this, but it's like a 1-to-1 of THC and CBD, which is, CBD was found to be effective with children with seizures. And I'm going to let her do that. But that really changed my life. It actually helped me in so many ways. Jandra, I met in 2022 or 2023 when I was in the midst of menopause hell. Interstitial cystitis was my diagnosis, but there was a lot more going on. And thank God they sent me to her, and she has been guiding me still for the last few years, and she guides all of her patients. And we all think so highly of her, and it's been great. And I'm just so happy she came. I had to keep convincing her to come. Lisa, I met through a surf program, and she owns the ketamine clinic, and I recently went and did 5 infusions there because this past year I had 3 surgeries, abdominal surgeries, And when it was all over, I just got very, very depressed. It was probably the worst depression I'd ever had. So, I was always sending my patients, and I went, and it was great. It really helped a lot. So why should you listen to me about pain? Who am I? I'm a therapist. I'm a trauma therapist. But as I just said, I'm also a patient. And when you're a patient, you spend many, many years seeing many, many providers. Most people don't get their diagnosis of a chronic illness before 5, sometimes 10 years. So there's a long time where you're seeing doctor after doctor, naturopath, everything. And, it's a very complicated thing to treat. And if you've got, one of the things I want to stress is that there is a real physical cause of the pain. Pain is called nociceptive pain. It's there. If you look at someone with interstitial cystitis, you could see in their bladder, you can see the redness. It's there, but it's easy when we're providers to kind of, we can't really imagine it until it's happened to us. So it's a real physical cause, but it then causes stress, distress, and then anxiety and depression are not far along. Your world becomes very small when it gets bad, and you get isolated. And, when you go to a therapist, someone like you, that's the first thing we say is, oh, you're depressed. Let's see what we can do about that, which is definitely something we need to do. But we also need to collaborate with our patients and try to collaborate with their doctors. It's not easy, but I have found when I contact their doctors, they're really happy to talk to me, because the doctors are also overwhelmed when someone comes in with like 25 symptoms. Some of these people I have 100 symptoms that are all related, and they sound like they're crazy when you see them. So I wanted to just get some definitions out of the way, but mostly what I want to be talking about is what my experience was and what my patient's experience is. My pain, is it not in here? Hold. I might have put it earlier. We'll just start with the definitions and I'll get to it. So what is the definition of chronic pain? So chronic pain is pain that endures past the normal recovery. And the older we get, the normal recovery gets longer and longer. So, you go in and they're like, oh, hysterectomy, 6 weeks. It's not 6 weeks. But, if it's 6 months later and you're still having a lot of issues, that's time to go and find someone like Jandra and talk about it. Chronic pain is, many of you may have a bad neck, a bad back, you've injured yourself. You do something wrong and it goes out and you can't do anything. Maybe that happens once a year, twice a year, maybe 3 times a year. But when it starts to be every week, twice a week, or it starts causing other issues like headaches, overall body aches, anxiety, that's when we talk about it being chronic. Chronic pain it's kind of, it's hard to define exactly, but I think the best way is to just think about how is your life quality with whatever it is you're dealing with. Are you dealing with something called IBS, irritable bowel syndrome? It's every patient I have has IBS in there. IBS is a miserable thing to live with. It makes your world exceedingly small. How are you going to get out and do what you want to do when you're tied to the bathroom? So chronic pain can accompany a long-term health issue as well, like arthritis or autoimmune diseases, fibromyalgia. And Michelle will speak to this more, but we have something called central sensitization, and that's kind of what's behind our emotional reactions and our physical reactions, and that's very much influenced by childhood trauma. The Kaiser study in 1999 was done in a weight loss clinic, and they found that most of the patients with more than 4 out of the 10 adverse childhood experiences were, at like a 90% risk of having 9 of 10 out of chronic diseases. It's something that's helpful to talk to your patients about, but it's not the first thing. Oh, you're feeling really sick because of your childhood trauma. They're like, I don't care. I don't want to be in pain. When you have an autoimmune disease or something like that, it can manifest as intermittent episodes called flares. And I'm sure you probably met someone who has arthritis and they're like, I'm having a bad day. Like it's cloudy. All my joints are aching. I feel like I have the flu. I'm tired. And then the thing about being in chronic pain is it's invisible. So you don't really know, looking at me, how am I feeling today? We end up sort of functioning and masking. And it can really, when someone asks me how I am, I can just say, I'm having a flare day or whatever. Flares also can cause fatigue, and fatigue is actually the most disabling piece of all of this. You've probably heard of long COVID. It's starting to get a lot of press. Long COVID has the same symptoms as chronic fatigue syndrome. And chronic fatigue syndrome is extremely disabling. It can hinder your ability to work, maintain a proper diet, engage in physical activities, or find enjoyment in life. We're told move, 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 but for some people, moving causes a lot of pain. And then there starts to be this involuntary sedentarism. And you'll hear from friends, family, doctors, well, start doing this and you'll feel better. Start eating this, you'll feel better. All of that is true, but it's not, we still have this physical component that needs to be treated. So you can, I over the years, I did everything, diets, Ayurvedic medicine, all that stuff. My neck was so bad, the idea is that it would make me able to cope with my neck pain, but it just never really did. And then I'd become frustrated. And then I'd feel a lot of shame and judgment from people that just, didn't understand. And I have so many young patients and they're not understood and people think they're lazy and it's just really hard for them. And then in the end, it can lead to what is known as high impact chronic pain. And that's when you're completely disabled, bedbound, on disability. And I have many of those patients as well. And like I said, it's central sensitization. It's a disease in itself. How prevalent is chronic pain? I went through so many things. I wanted to find the exact number. I don't really know the exact number. These are some of the estimates that are out there with all their sources. The most recent update I have is 60 million with the Pain News Network. I personally think it's higher.
Reported.
Yeah. And then autoimmune diseases are really important for women's health because women have 80% or 75%, depending on who you talk to, of all the autoimmune diseases. And it's kind of interesting why. Why do women have more? And there's a lot about what we're taught to be as a woman, which is to kind of take everything. And if you've read Gabor Mate, he has a real theory that the young person who takes on everything is the adult with an autoimmune disease. This is another source of it. 1 in every 5 has an autoimmune disease. This one says 75% are women. There's more than 100 diseases. I think there's even more than that. Okay, hold on. And then if you kind of overlay that, because autoimmune disease usually has pain with it. Other diseases have pain, like Lyme disease. I don't know if you've met anyone who has Lyme disease, but it's very debilitating. They have severe headaches, fatigue, all kinds of skin issues. So you start to overlap. Chronic disease is more like kidney disease, heart disease, kind of the regular ones when you're on your form and they say, do you have this? When I do those forms, I look really healthy. So I'm like, yeah, I look great here. No, I'm not great. So I just put a big circle and I just feel like, especially with the politics and the toxic stress everyone's under, I feel like everyone's kind of dealing with something. Let's go back. So I just briefly will tell some of my story. I want to focus more on my patients because I have my story all in that book. And that book is free because it's my first print and it has errors in it. So you can fight over. It's still okay, but you can fight over it. But my pain started in the womb. And I'm not the only person this has happened to. I have a sister named Liza, and she is 15 months older than me. When she was born, she got very sick and they thought she was going to die. And they thought she was going to die for a long time. So my parents decided, oh, let's have another baby, which when I became a mom, I was kind of like, what were you thinking? I don't know what you were thinking. So the whole time I was in the womb, my mother was dealing with a dying child. Dealing with a dying child is very stressful and upsetting. And a lot of the science, I don't know how much is proven, but babies are affected by stress in the mother, and it doesn't have to be a dying child. There's many, many things. So when I came out, I was already like genetically predisposed. There was no way I was getting out without anxiety. I had some of the serotonin transporter genes. I did a genetic test and I came out as like, I think it said unstable amygdala. And my psychiatrist was telling me that. And she came and sat down next to me and she's like, look, and I'm like, oh, so I had no chance. She's like, yeah, no chance. So I was effed from the beginning. My sister never died. But when I was growing up, she was still dying. And she wasn't doing any of the developmental steps that kids do. So when I came in, I started to walk, crawl, all of that, and she would do it right after I did it. So I never really got much attention. I mean, it was for a real reason. They were very busy with this. I had grandparents, but I had an older brother. He was getting that. So I just kind of was there, not getting much validation, care. When I was born, the home was filled with terror, hypervigilance, and grief. Never really went away. I absorbed this through implicit memory stored in the body. And, and that's a lot of the reason that I have all of these emotional and physical issues. Later, my feelings were invalidated because I would say, oh, I wish I didn't have a disabled sister. And my mother would say, well, you're lucky because you wouldn't exist. And so this idea of existence, so I've spent my life trying to validate my existence, So here I am talking, y'all, like this is like the ultimate trauma repair, like the child who, so I had to justify my existence over and over. Then as a child, I was also born with my C4 and C5 had a narrowing, was congenital. And nobody really knows what this did, but it's basically squeezing a little bit on your spine and your vagus nerve and all that. And I used to, when I'd get, for reflexes, I'd be like, ugh, like I just like see it. So it's been fixed. So that's been a lot better. But as a kid, I was, I had a lot of depression and loneliness. But in between that, I was out playing, out doing sports, making a lot of friends, all of that stuff that kept me going. I had a nice neighborhood. I had other parents to go to. I mean, my house was very silent and people didn't like to come to it, but I went out and I thought I was fine. I had no idea. And later in my 20s, things started to get a little harder. I injured my neck at 27 and it was fixed at 45. And then I began my journey with endometriosis, interstitial cystitis, IBS. That's when I entered Jandra's life and she guided me through all of that. And hormones were a huge piece of that. And that was really interesting. And she can talk more about that, how interstitial cystitis is it's same tissue with the vestibule, I believe. So if you have a hormonal, you don't have the right hormones, that tissue can get irritated and is shared with your bladder. So a lot of people with interstitial cystitis don't really have true interstitial cystitis. I think my story is lucky in many ways right now because right now I'm experiencing the best health I've ever had. I had a really hard year. I had the endometriosis surgery, but there was a gallbladder issue along the way. Then I had appendicitis and then I had my gallbladder out. But now I've actually had times with no pain, which is amazing because the normal amount of pain is no pain. Some days I do though. It's not every time. So Autumn was going to do a lot of the information about kind of the state of women's health. And I'm just going to touch on it briefly because I think everyone else will speak to it. But you know, as a woman, you've been walking around with cramps and pain your whole life, and it's been normalized. When we say it hurts, it's almost immediately thought to be stress. And you're like, yeah, it's stress, but I'm stressed because I'm in pain. How often have you been in a gynecologist's office or another office with your paper gown and a doctor there telling you, that's not really what you're feeling. This is what you're feeling. And you're kind of, you know, in the inferior position in that way. So a lot of the work I do is trying to help patients advocate for themselves and go in and, you know, try to get listened to and be accepted as a true historian. We're not accepted as valid historians of our symptoms. This isn't every doctor, but, you know, the doctors are humans too, and they don't have a lot of time, and a lot of them don't really have time to research all these complex illnesses. So when you come in, they're just like, okay, let's just focus on this one thing. And it's just, you know, being a woman in the healthcare system, it's not designed for us. The research wasn't there for us. And so women walk around masking their pain, and we're just used to it. As I said before, we can have a huge delay to diagnosis. You know about the hysteria legacy, so more women are offered Ativan in an emergency room than pain medicine. The early socialization, be nice, don't make waves. Gabor mate, that's the adult autoimmune patient. The invalidation over and over and over leads to shame, leads to low self-worth. And you start to question, well, maybe I'm not in pain. Like maybe that kidney stone wasn't really that painful. Women's pain and men's in ER visits. We're more likely than men to have our pain dismissed as emotional or psychological. I did get in one of my ER visits this year, she gave me Ativan instead of pain medicine. And I was like, whatever. And studies show that women reporting pain are more frequently prescribed sedatives, while men with similar symptoms are more likely to be prescribed pain medications. We're also likely to be treated less aggressively until we prove that we are sick. I actually had that happen to me when I was much younger. I found when I'm older, they treat me a lot better. I think when you're a young woman, you go in with pain, they're like, well, you look fine, you're young, whatever. Because I went in with a kidney stone when I was like 33, and I knew it was a kidney stone. And they're like, oh, it's an infection. And they didn't give me any medicine. And then when they found it was a kidney stone, all of a sudden they gave me medicine. So I was suffering there. And the more that you suffer with pain, the worse it gets. One of the most validating podcasts I ever heard was something called The Retrievals. Any of you heard of this? Yeah, Janda told me about this. So this is a New York Times serial, and this was a Yale fertility clinic, and women were going in to get the procedure of egg retrievals, and one of the nurses there had been addicted to fentanyl, so she was swapping out saline into the fentanyl, and these women were getting saline instead of fentanyl, and nobody believed them when they were in pain. And there were ones, like one was a trauma surgeon, and she knew it. She's like, I can taste the saline. But she went through it because, you know, it's a timed thing. You can't just, okay, we'll just do it next week. And they're all just saying, well, you know, you're not relaxed enough. You know, and when you're sitting there, they all felt there was something wrong with their body already because they couldn't have children. And so they just accepted, yeah, you're right. I'm just not relaxed. Like, this isn't that bad. Later, they all got a letter in the mail. I mean, they thought it was just a bill, and it just said, oh, by the way, you know, there was no fentanyl in there. And this caused tremendous suffering, and they got together to do a lawsuit. And the first thing the lawyer said, well, what's the damage here? You know, you had a baby. There's no damage here. Many of these women were left mistrusting healthcare, severe trauma. You know, it's like the objective evidence of they did not get pain medicine. They were in pain. Nobody believed them. If that's happening, imagine. So I just wanted to kind of get a few definitions out of the way. Medical trauma is a little bit different than classic trauma in the sense that it's ongoing. When you're experiencing medical trauma and you're going to doctors and you're being dismissed and you're scared and you don't know what's happening, you keep getting re-traumatized. And it's kind of like, how do you treat this if it's ongoing? Like, what do you do with somebody who's in an abusive relationship and comes to you like, we do EMDR, but I'm still going to stay in this relationship? Well, I can try, but if you still keep going back and getting re-traumatized, I don't know how much I can help. We can help, but that's just something to keep in mind, that, you know, a lot of the job is really holding their hand and, you know, believing them. And I always say there's somebody who can help you. When people have low socioeconomic status, it's really hard. That's like one of the worst, you know, when they do like diversity, like what's the hardest thing when you're a therapist? This is the hardest thing I come across, because most of the help that I got, I had to pay cash for. And I feel very constrained when I have to help them through this and they have no options. And I don't really have an answer for that. Medical trauma is not a DSM diagnosis. So I call it complex PTSD, parentheses, medical. It can result from a single event like a surgery or an accident, ER visit, or chronic invalidation over time. It's exceedingly common in patients with chronic illness, pain, or misdiagnosis. I must have been in the ER in the last 10 years with abdominal pain like 20 times. And I left most of the time with unexplained, because this whole time I had endometriosis. And endometriosis you can't see on a scan. And it was all over all of my organs, and I had no idea. And medical trauma is rooted in what's happening medically. And again, we're being told we're not reliable historians, and it's not always purposeful. One of the things that causes medical trauma is medical gaslighting. Have you guys heard of medical gaslighting? So medical gaslighting is a little different from like the gaslighting definition that most people are used to with relationships, with a spouse saying, no, that's not what happened. This is what happened. And medical gaslighting is not necessarily intentional. Sometimes it's to silence the patient, but sometimes it's just they don't know what's going on. And their language can lead to feelings of being gaslit. So the language can be labeling a patient as a frequent flyer, assuming a diagnosis based on sex, race, identity, refusing to explain or discuss a diagnosis, minimizing debilitating or dangerous symptoms, saying things like, you are probably working too much, you are too fat, you are too skinny, you need to drink more water, you need to eat more fiber, you can't possibly know just because you feel it, you need pain management. But pain management isn't going to magically take away all of your pain. That was from Alana Jacqueline. She has a great book called Gaslighting. I highly recommend it. I put it in the resources. She says the goal, whether intentional or incidental, of gaslighting sometimes is to silence the patient, discourage further questioning, and make them drop medical pursuit. You like this, dear? And just how does medical trauma show up? So we have the basic trauma responses: fight, flight, freeze, and fawn. And these show up in the office as fight, anger, confrontation, refusal of care. This can then affect the doctor, because the doctor has a trauma response too. So the doctor might have had an angry father, and as soon as that happens, they kind of retreat, they kind of flee, and just don't provide you. Flight is avoiding appointments, leaving settings. I had a patient who just, left, ran out of her session crying. Ran all the way to the car and cried all the way home. Fawn is like agreeing to everything, people pleasing. This is mine of choice. Whenever they move me into surgery, I'm like, thank you, everybody. Thank you. You know, I really appreciate you, so that they take care of me better. So I'm going to be, you all have a handout. And we're gonna have a little exercise here. And then we're gonna redo the exercise after my talk. You're gonna see patients who say, I'm allergic to most medications. I've tried everything for anxiety and depression. Nothing works. I have reactions to toxins and chemicals, perfumes, electricity. And you're kind of like, I think they're crazy. They're not crazy. Their limbic systems are overreactive. It doesn't mean it doesn't turn into severe anxiety that can then cause it. It's very complicated. This is one of my surf therapy participants, and she has given me some art, so you're going to see it here because I just love it. And this is her her painting of I Feel Fine. But meanwhile, she was on steroids, and she was like, ah. So everyone who is born holds dual citizenship in the kingdom of the well and in the kingdom of the sick. Although we all prefer to use the only good passport, sooner or later, each of us is obliged, at least for a spell, to identify ourselves as citizens of that other place. So people with chronic illness and chronic pain are living in that other place, on that other planet. Their days are spent calling insurance, making appointments, getting medications, trying medications, having procedures, recovering from procedures. None of this time is very, it's not very satisfying time. It's not like when you clean a car and it's all clean. This is just working every day just to feel a little bit normal. So you have it in your sheet, but I'm just we're doing patient cat, and I'm just gonna quickly, this is your intake you're getting. She comes in and she says she has endometriosis with chronic pelvic pain. She has hypermobile Ehlers-Danlos syndrome. She has POTS, which is postural orthostatic tachycardia syndrome. She has a Bartonella infection, which is a Lyme type disease, and it contributes to a lot of these inflammatory flares. She has dysautonomia with orthostatic intolerance, autonomic reactivity. I mean, if you think about what that is, it's really like your whole body's just not wanting to, it can't handle the environment. And, you know, you may have had this happen when your blood sugar gets low or something and everything's just kind of out. It's really kind of scary, very scary. So the emotional and psychosocial impact she's dealing with is invalidation and gaslighting. She has fear before appointments, mistrust of ER care. She has anxiety and anticipatory dread, sleep fragility, hypervigilance about flares and vitals, grief and identity disruption, loss of athletic self, loss of career, loss of safety of body, isolation versus community, withdrawal when she's having flares or when she's feeling sick. A lot of us end up sort of alone in our houses. And isolation it has a physiological effect. Her cognitive load, she's constantly having to advocate, do paperwork, coordinating special care. If you put like a job description of someone with chronic pain, they would look like someone who works for an insurance company. And then her developmental and intergenerational trauma. So she also has maybe an in utero thing. Her mother was born in post-war Poland. Her grandmother was pregnant under extreme wartime stress. Biology 101, and I'll let Michelle tell me if I'm right about this or not, but a female's primary oocytes form in utero. So Kat's eggs begin developing while her mother was a fetus in her grandmother. So the emerging science is that prenatal early life stress is linked to epigenetic and neuroendocrine changes, so kind of like what happened to me. And the clinical prevalence is she has a heightened threat detection, dysautonomia reactivity, POTS, and pain amplification. So I don't have it on here, but so those are the three things. And then if you see, when those are over, I have exercise. So pick a partner and take about 5 minutes. And the first question is, what is your initial reaction when you see this case? And the second one is, what would your priorities be for the first few sessions? And so take a little time, you know, not a huge amount of time, and just see what you think. And then we'll do this. You didn't have to write a whole essay about it or anything. Just so. So some of the themes in chronic illness, I think I've kind of spoken to a lot of them. You know, I'm not going to read everyone, but the dismissal by friends is also a big deal. You start, depending on who you're hanging out with, you end up not having people that understand, and you can feel like you're just, like I said, you're on another planet, and you find yourself sitting at dinner and they're kind of all talking about things, and you're just sitting there, well, I can't even sit up for this long, and what do I have to talk to? What do I have to contribute to this conversation? So this is my patient participant, and this is the little art show, and she's saying in this one, this is what life is like navigating an illness. She's got that big killer whale coming up. Chronic illness requires immense strength to manage daily life. Many feel misunderstood, invisible, or like a burden. So recognizing their courage, their engagement itself is resilience. Acknowledging the effort it takes to show up. This share was one of my participants. The solution was always meds. No one asked how I was coping emotionally. It's not just the pain, it's the emotional struggle of trying to live a normal life. So our role is to hold the emotional experience of chronic illness. Then there's the grief piece. Grief is a huge piece of chronic pain. And when you finally get your diagnosis after years and years, this patient said she felt relief and grief. The validation brought both comfort and loss because this was something that was not going to be cured. This was something she'd have to manage. And this is very similar to grief, when that moment when somebody passes away and you realize, oh, this is real. Like, I just have to live with this. And that's usually when they show up with me, is when they hit that. Because before that, everything's kind of, what do I do next to fix this? Fix. And then when you're told, there's no fix, there's just living with it. And I tell them, well, we can live with it and make your life quality as best as we can. And the identity often reshapes around connection and meaning. Many of my patients I've got the little gaslight here, I'm just going to bring into appointments. Medical gaslighting that began in childhood, years of dismissal before accurate diagnosis, invalidation by trusted professionals caused deep trauma. All we can do is model ethical, attuned listening to rebuild safety, and to also, we kind of turn into case managers a little bit when someone comes in and says, I've tried everything, I'm in pain. They told me to go see a psychologist because it's all stress. Yes, it's all stress, but there's a physical reason, there's something going on, and we end up having to help them with that, which isn't a comfortable thing for everybody. If you haven't experienced it or don't know much about it, you don't know what to do. You're like, I don't know. I know a lot of things, but I don't know much about some of the diseases. And so it's really asking them what it is, what the experience is, and then doing a little research. Like, you don't have to become an expert, but, or reading some of these books that there's a lot of books that are kind of memoirs of people with illness that really capture it really well. I mentioned earlier that fatigue is often more disruptive than the pain. There's a comparison to torture, because torture, you're getting pain inflicted with no end. You're isolated, and then, they often play the music and make it really loud. But that's kind of when you have all this, you're already hypersensitized. So just living, it causes you a problem because you're just hypersensitized to everything. If I don't fight for myself, no one else will. There's a lot of fatigue in advocating for yourself, having confidence in yourself. I found myself in the hospital last year with appendicitis, and the night surgeon saying, oh no, it's not that bad. And I had to really advocate and have to call my husband. And it was just, and here I was like, I know what's going on, but I'm still having a problem here. And I still felt like a burden when they wheeled me in because it was midnight. And the guy wanted to watch the Rams game or something. I'm not sure what was happening. Grief. So I in grief, I have a little paper I wrote about this where I use grief as the model, and I use Worden's model of grief, which is accepting reality of loss, 2, experiencing the motion, 3, adjusting to life with illness, and 4, moving forward with it. But the other thing that's happening is Maslow's hierarchy. If you look at it, the bottom is physiological: breathing, food, water, sex, sleep, homeostasis, excretion. So if you're having intestinal issues, constipation, you're not excreting, you have painful sex, you can't sleep, how are you going to do all these other things when that's your world? And then the next one too is security of body, of employment, of resources, of family, of health, of property. Those are also at risk. And so we're dealing with all of that. And yet we all as people want to get up to self-actualization and esteem. It doesn't mean we can't do that with their safety issues, but it's extremely hard. And that's a lot of the first part is helping with the physiological and the safety. And a lot of that, like I said, is kind of a case management. And, you know, if you don't know all the doctors and you know all that, you can, yeah. Oh, hold on. Why did that happen?
It bumps us off sometimes. I'm not sure why.
I think it's like a security thing because they keep changing the code. How long was it not showing anything? Oh, okay. I could be talking and so, you know, if this is when you reach out to someone like Jandra or someone like me, I'm happy to talk to you. I'm not here to charge $1 million. I'm happy to share whatever I can because there's just so many patients. So this is that same participant, and this is her little series. So this participant has something called CIDP, chronic inflammatory demyelinating P. Her motor neurons don't continue down to her feet or to her extremities, and yet she's out there in her surf therapy, and she just lays on the board, and her husband pushes her, and it's really beautiful. But she made this series for me, so this one is, I feel like, and this is all like surf therapy themed, okay? That's why I showed you that. So I feel like I'm drowning in my chronic disease. Stung, learning. I got a bunch of us got stung by stingrays this summer. I know that's not a great advertisement, but it actually was kind of interesting because everyone kind of got through it and felt stronger because it gets better. So when you have a chronic illness, there's something, well, I'm in pain for 4 hours, but oh yeah. Not recovering, but doing a little bit better. You're doing great. Proof is right in front of you. And that's her on the dock, hopefully not falling in. And I was talking about loneliness, the physiological effects. It can increase inflammation, dysregulate cortisol, and alter immune function. So she made a little surf, yeah, that's what they call it, a groundswell surf sisters. And she made this little painting. I got this some days. Beginning and ongoing. Okay. And so finally, just a little bit of advice, I guess. You don't know what you don't know. The biggest intervention we have is our relationship. And identifying and normalizing and validating. Like I said, pain has a physical component that needs to be treated. And unfortunately, it's undertreated for many different reasons. Why validation first? Because people need to be seen and heard. It downshifts threat. It counters gaslighting, restores credibility. An alliance will predict engagement more than technique choice. This is floating, but stinging people close to me. She gets pretty irritable and really barks at people, but it's hard. You know, she's floating up there trying to live and yet constantly angry about the situation. You know, grief is like that. The emotions of grief there's not just one emotion and they go over and over. When you have grief, it doesn't really end. It gets a little better over time. and you just have different emotions. And so whatever emotion you're feeling right now, it's not going to be forever. But you're going to have days of fear, days of anger, days of hopelessness, all of that. But hopefully over time, you'll live with the disease, honor the disease, be able to say, I'm having a bad flare, I'm going to rest, and that's okay, and not think, oh, I'm not doing anything, so I'm not worthwhile, I have nothing to give. It's living with anything, mental illness as well. This isn't that much different. And just stay in your lane, stay in the relationship. You're not a doctor. You may be tempted to give medical advice, but these are just my thoughts, not medical advice. Collaborate, don't overstep. And then what patients say they would like you to do, thank you for your advice, and please fuck off. They don't want to hear yoga, meditation. These are all good things, but brought in at a later time, saying, we're trying to help you live with it. This is not going to fix it, but how do you live better? That's where trauma therapy comes in. They like psychoeducation. I did, once I realized all that, all my shame went away. It's not my fault is a big thing. And again, the shared themes across stories: emotional detachment and over preparation, a fear of dismissal and invalidation, mistrust built over time, small acts of self-advocacy and healing, and we use therapy as a transformative tool. We surf in pain with help. So takeaways: patient stories and neuroscience align, hold both truths, symptoms are real and impact is emotional, begin with the relationship. And then I'm not going to read this all out. You can ask later. That we do have some lectures, one with Michelle. I just wrote this book. It's on your table. Here's some books that I really recommend, and those are in your handout. We have someone here, Janine, who just told me about her book, which I'm excited to read. Yeah. And these are just a couple of the CEUs that are out there. Lisa, Natalie, and I did a psychedelics and surf therapy CEU, and then Michelle and Natalie and I did intersection of plant medicine ecotherapy. And yeah, that's it. Thank you.